You know, usually when we talk about a medical diagnosis or a clinical procedure, there's this underlying expectation of just pure mechanical precision.
Right, right. Like it's all math.
Exactly. Like
Yeah.
you break your arm, the x-ray shows this very clear, jagged white line on the bone, and the doctor just points at the screen and says, well, there it is. That's the problem, and here is exactly how we fix it.
It's a very comforting illusion, honestly.
Yeah.
I mean, we like human biology to be visibly, neatly categorized into, broken or fixed.
But the moment you step into the world of intimate human anatomy, tissue mechanics, and sexual wellness, suddenly that x-ray machine is completely useless.
Oh, completely.
We're looking at a clinical landscape that is murky, it's highly individualized, it's just incredibly complex.
Which honestly makes it the perfect subject for us to investigate today.
I completely agree. So for you listening right now, the learner who is just endlessly curious about how things actually work under the surface, we are pulling you into a really fascinating intersection of intimate wellness and biomaterial engineering.
Yeah, we're answering a highly specific but honestly incredibly revealing question today.
Right. What structural properties differentiate monophasic versus biphasic hyaluronic acid fillers when they are used for G-spot augmentation?
And to get to the bottom of that, we've gathered a really compelling stack of sources. We're looking at clinical aesthetic guidelines, medical case reports, some really dense scientific papers on a field of physics called rheology.
Super dense.
Yeah, very dense. And we're balancing all of that mechanical data with the official committee opinions from the American College of Obstetricians and Gynecologists, or ACOG.
So whether you're tuning in because you're fascinated by like the chemistry of hydrogels or the physics behind cosmetic procedures, or you just want to understand the science of female sexual pleasure,
Yeah.
this deep dive is going to break down exactly how molecular structure dictates physical sensation.
Definitely. And, to understand why the chemistry of a specific gel even matters in the first place, we first have to understand the anatomical environment we're dealing with. And, of course, the precise mechanical goals of the procedure itself.
Okay, so the procedure we are exploring is often marketed in aesthetic clinics as the G-shot. But before we can talk about the shot, we need to locate the target.
The target being the G-spot.
Right, the Grafenberg spot.
Uh-huh.
According to our clinical sources, this is an erogenous zone located on the anterior vaginal wall.
Yes, that's the front wall. It's positioned vertically, right up against the urethra and the bladder.
Okay.
Anatomically, it's generally described as being located about 2 to 3 centimeters, so roughly an inch or so inside the vaginal entrance.
Right.
And it's an area that's just dense with nerve endings that, for many, is deeply connected to heightened arousal and very specific physical responses.
But the sources also make it really clear that finding it isn't like, finding a belly button.
No, not at all.
It's not this distinctly outlined separate organ. Because of individual anatomical differences or hormonal shifts or honestly just the natural aging process, some individuals feel that the sensitivity in that area has diminished over time.
Right, or the tissue itself is kind of flattened out, which makes it much harder to stimulate.
Which brings us to the mechanical intervention. The aesthetic sources describe this augmentation as a minimally invasive outpatient procedure.
Yeah, it takes about 15 to 30 minutes in a clinic.
Just a quick in and out.
Exactly. After applying a local anesthetic to numb the tissue, a clinician injects 1 to 2 cc's cubic centimeters of a biocompatible hyaluronic acid filler submucosally.
Meaning it's injected just beneath the mucous membrane of that anterior wall.
Right, exactly.
And the physical goal here is what really caught my attention. I mean, they aren't trying to build a new anatomical structure from scratch, right?
No, they're trying to amplify an existing physiological response.
So the aim is to expand this target area to about the size of a quarter or like a large button and maybe the thickness of a pencil eraser.
Yeah, and by doing this, the tissue is quite literally forced to bulge outward into the vaginal canal.
It's kind of like building a customized speed bump on a smooth road to, guarantee tire contact.
That is actually a really perfect analogy. The underlying logic is entirely about physical mechanics. By increasing the volume and thickness of the tissue, you increase its prominence within the canal.
And a more prominent tissue mass means a larger surface area.
Exactly, which dramatically increases the likelihood of direct, consistent physical contact during intercourse.
But okay, here is what I can't quite wrap my head around. The vaginal wall isn't a static, flat surface.
Not from it.
It's highly rogated, meaning it's heavily textured and folded to allow for expansion. And during intimacy, it experiences immense dynamic physical pressure and friction.
Oh, absolutely.
So how does injecting a liquid gel actually create a stable, projecting speed bump shape without just instantly squishing flat under all that force?
See, that question takes us directly to the core of this deep dive. To answer how a gel holds its shape against those sheer biological forces, we have to look under a microscope.
Okay, let's do it.
We have to see how these fillers are actually manufactured, because not all hyaluronic acid is built the same way.
Right. Not at all. I mean, hyaluronic acid, or HA, is a naturally occurring sugar molecule in the human body, right?
Yes, you have it in your skin, your joints, your eyes. It acts as a humectant.
Meaning it binds to water molecules to keep tissues lubricated and volumized?
Exactly. But natural HA has a massive flaw when it comes to clinical enhancements.
Right. The body's just way too good at recycling it.
Exactly. It breaks down incredibly fast. We have these natural enzymes called hyaluronidases.
Hyaluronidase?
Yeah, and they constantly clear out old HA to make room for new molecules. If a clinician injected pure natural HA into the vaginal wall, those enzymes would dissolve it completely in a matter of days.
Which completely defeats the purpose of going into a clinic for an enhancement procedure in the first place.
Right. So biomaterial engineers step in. They chemically modify the HA to make it durable, and they do this through a process called cross-linking.
Okay, cross-linking.
They introduce a chemical agent. The most common one in the scientific literature is called BDDE.
BDD.
Yeah. Think of BDDE as a series of tiny, permanent chemical bridges. It links the long, individual floating chains of HA together into this three-dimensional tangled network.
Okay, I think I get it. So instead of a bunch of loose strings floating in water, the BDDE bridges tie them all together into a dense, solid net.
Exactly.
It turns a liquid solution into a stable, viscoelastic gel.
Yes, and the specific way you create and process that net determines whether you get a monophasic or a biphasic filler.
Ah, okay. This is the big structural fork in the road we mentioned.
Precisely. Let's look at monophasic first. Monophasic fillers are formed through a process called homogenization. The cross-linked HA is continuously blended and kneaded into a single, smooth, uniform gel phase.
I was reading about this, and the sources mentioned these monophasic fillers have a higher degree of modification.
They do.
What does that actually mean at the molecular level, though?
So the degree of modification basically refers to how many of the HA molecules are actively attached to those BDDE bridges we talked about. In a monophasic filler, it's generally around 4 to 8%.
Okay.
That sounds small, but in polymer chemistry, it's quite high. It means a significant portion of the gel is tightly bound together in one continuous homogeneous phase.
Okay, that makes sense. So contrast that with biphasic fillers. How are they structurally different?
Well, biphasic fillers are formed through a completely different physical process. The HA is cross-linked into a solid block first, just like before. But then, and this is key, it is mechanically forced through a mesh or a sieve.
Oh, wait, so they are physically grading it down.
Yes, they are breaking the solid gel block down into thousands of distinct individual cross-linked particles.
Wow.
But, you can't just inject dry, jagged particles through a fine needle, so they suspend those solid particles in a carrier fluid, usually a non-cross-linked pure liquid HA. This liquid acts as a lubricant, allowing the solid particles to flow smoothly out of a syringe.
And structurally, because of that liquid carrier, these biphasic fillers have a much lower degree of modification.
Usually around 1%. Because only the solid particles are cross-linked, the liquid carrier fluid around them is not chemically modified at all.
Okay, here's where it gets really interesting to me. I was trying to visualize this physically.
Sure.
A monophasic filler is essentially like smooth peanut butter, right?
Yeah, that works.
It is one continuous, uniform, sticky substance.
Yeah.
But a biphasic filler is more like bubble tea. You have these distinct, firm, solid pearls, the particles suspended in a liquid.
Yes, exactly.
Yeah.
What's fascinating here is how those two distinct structures, the smooth peanut butter versus the bubble tea, behave when you inject them into a highly dynamic environment like the anterior vaginal wall.
And to really understand that behavior, our sources dragged us into the physics lab.
Deep into the weeds.
Deep in the weeds.
Yeah.
Specifically into a field called rheology.
Right. Rheology is just the study of how materials deform, flow, and react under mechanical stress.
Which is pretty important if you're injecting something into the body.
Absolutely. If you're going to inject a hydrogel into human tissue, you have to know its rheological profile. There are three major forces we need to examine here: G', cohesivity, and exotropy.
Let's start with G prime because the papers mention this constantly. It's also known as the elastic modulus, right?
Yes.
From what I gather, this is basically a measurement of how firm or stiff a filler is.
That's a good way to put it. It measures energy storage and resistance to deformation. Think of it like comparing a firm memory foam mattress to a waterbed.
Okay.
If you press your hand into the memory foam, it has a high G prime. It resists the downward pressure and firmly bounces back to its exact shape. The waterbed has a low G prime. It just yields and spreads out.
Right.
While biphasic fillers, the bubble tea, have a very high G prime.
Because of those solid sieved particles?
Yes, those distinct, rigid particles stack on top of each other, creating a stiff, microscopic scaffolding. They offer immense immediate lifting and projection capabilities against the surrounding tissue.
Okay, that makes perfect sense. So if the goal is to create that distinct speed bump shape on the G spot, you would logically want the high G prime of the biphasic filler.
You'd want that structural lift, yeah.
Right. But that brings us to the second force, cohesivity.
Yes.
How is cohesivity fundamentally different from firmness?
So firmness is about resisting downward pressure. Cohesivity is the internal adhesion force holding the gel together. It's how sticky the gel molecules are to each other when they are pulled apart or stretched laterally.
Ah, okay, so this is where the peanut butter versus bubble tea analogy really clicks.
Exactly.
Monophasic fillers, the smooth peanut butter, are highly cohesive.
Yeah.
Because they are one continuous, highly modified network, all the molecules want to stick together. If you pull it, it stretches, but it fiercely resists breaking apart.
While biphasic fillers, the bubble tea, have very low cohesivity, the individual particles don't actually stick to each other. If you try to stretch or pull at it, it instantly fractures and separates into clumps.
Okay, wait, I have a theory then.
Let's hear it.
If we are putting this filler into an area that experiences intense, repeated friction and shear force, wouldn't a high G prime biphasic filler just kind of scatter?
Right.
I mean, if those particles don't stick together, doesn't that beautiful, firm speed bump shape just get pulverized into a flat, bumpy gravel road under the mechanical stress of intercourse?
If we connect this to the bigger picture, you've just articulated the exact clinical dilemma doctors face. You're absolutely correct.
Wow.
The biphasic filler gives you incredible vertical projection. It pushes the tissue out beautifully initially, but because of its low cohesivity, it is highly susceptible to being separated and migrating when exposed to the lateral shear forces of intimacy.
But the monophasic filler.
The monophasic filler, being highly cohesive like smooth peanut butter, ensures that the material sticks together. It moves naturally with the mucosal tissue.
So it just goes with the flow.
Right. It stretches and bends, resisting the urge to break into smaller, isolated islands under that same friction.
But because it's softer, because it has a lower G prime, it might not give you that distinct, firm shape. It might just flatten out more into the surrounding tissue.
Exactly. It's a massive structural trade-off. Which brings us to the third piece of the rheology puzzle, which honestly complicates this mechanical environment even further.
Which is tan delta and thixotropy.
Yes.
Break those down for me because thixotropy is just a wild concept.
So tan delta is simply a ratio. It compares a gel's viscosity, its ability to flow like a liquid, to its elasticity, its ability to bounce back like a solid. A lower tan delta means the material acts more like a solid jelly. A higher tan delta means it acts more like a flowing syrup.
Okay. And how does thixotropy play into that?
Thixotropy is a highly counterintuitive property of these gels. When a thixotropic gel is placed under continuous repetitive shear stress like intense friction, the molecular bonds temporarily stretch out and align with the direction of the force.
Wait, really?
Yeah. As a result, the gel actually becomes thinner. It temporarily loses its solid structure and acts more like a liquid.
Wait, so the physical act of friction essentially melts it?
Only temporarily.
Yeah.
Once the mechanical stress stops, those chemical BDDE bridges snap back into their resting state, and the gel gradually recovers its original thicker shape.
Okay, so what does this all mean for the patient in the clinical setting? A doctor has to look at these physical properties and make a very deliberate choice, right?
They do.
And because this filler is injected submucosally right under the surface of the existing tissue, that rheological choice dictates entirely what the enhancement actually feels like to you, the patient.
Exactly. If a doctor prioritizes cohesivity and chooses a monophasic filler, the patient and their partner are likely to experience a more widespread, flexible, integrated plumping of the area.
Right.
The tissue feels naturally fuller and moves seamlessly with the body, but perhaps feels less distinctly targeted.
But if the doctor prioritizes projection and uses a high G' biphasic filler, The result is going to feel much more like a distinct, firm nodule, a very specific structural bump, even if it carries that risk of scattering over time.
Yes. And yet, regardless of which structural path is chosen, these procedures are temporary.
Which is important to note.
Very. Our sources indicate that the noticeable physical effects generally last between 4 to 6 months.
Because eventually, those natural hyaluronidase enzymes we talked about earlier catch up.
Right.
They slowly cleave those chemical bridges, breaking down the cross-linked HA, whether it's the smooth peanut butter or the bubble tea. The body metabolizes it, and the tissue returns to its baseline state.
Which, forces us to step back and look at the broader medical consensus surrounding this temporary augmentation.
Yeah, we have to talk about that.
While the aesthetic guides dive deep into the mechanics of the gels and exactly how to inject them, the official medical bodies offer a very stark warning. We really need to look closely at the committee opinion from ACOG, the American College of Obstetricians and Gynecologists.
Yes, this is crucial context. ACOG provides a highly objective, evidence-based stance on elective female genital cosmetic surgeries.
And we're just reporting what's in their official opinion here.
Exactly. They state explicitly that procedures intended solely to alter sexual appearance or function when there is no underlying clinical diagnosis are not medically indicated.
To be precise, ACOG draws a hard line between aesthetic enhancements and treating actual medical conditions.
Right.
If a patient is diagnosed with clinical female sexual dysfunction, or they are experiencing pain with intercourse, or they're needing repair from an obstetric injury, or undergoing gender affirmation surgery, those are well-established clinical indications.
But if someone is seeking the G-shot purely to amplify a sensation or alter their anatomy without those specific clinical diagnoses, ACOG classifies it as an elective cosmetic procedure.
And for those elective procedures, ACOG warns that safety and effectiveness have simply not been established by robust peer-reviewed clinical trials.
And they note that the vulvovaginal anatomy is incredibly diverse, right? It's dense with complex neurovascular networks.
Extremely complex.
They actually list some severe potential risks that patients have to be counseled on before undergoing something like this. We're talking about the risk of altered sensation or even completely lost sensation.
Yeah.
Severe tissue scarring and dyspareunia, which is the medical term for persistent pain during intercourse.
It is a vital reminder that we are intervening in a profoundly complex biological environment. Introducing foreign materials, even highly biocompatible ones like cross-linked HA, carries inherent risks that just have to be weighed meticulously against the purported mechanical benefits.
We started this deep dive looking for that clean X-ray.
We did.
We wanted a perfectly engineered binary answer for how to build a structural enhancement in intimate tissue. But what we found is that the human body just doesn't do clean engineering.
No, it really demands continuous biological compromise.
We learned that the physical success of the G-shot relies entirely on navigating the structural trade-offs of hydrogels. A clinician has to choose between the smooth, highly cohesive, uniform network of a monophasic filler, which stretches and resists separating under extreme friction,
and the rigid, firm, particle-based scaffolding of a biphasic filler, which gives incredible immediate vertical lift, but lacks that internal stickiness.
Right. It requires matching the exact physics of a lab-created polymer to the relentless, dynamic biomechanical demands of human tissue.
It really is an incredible collision of chemistry, rheology, and human anatomy.
It is.
And, this raises an important question, something for you to ponder long after this deep dive ends.
Okay, hit me.
We know these HA fillers are naturally degraded by the body's enzymes over 4 to 6 months, right?
Right.
But remember the phenomenon of sexotropy we discussed, where gels thin out and temporarily lose their structure under continuous physical stress.
Yeah, where the friction temporarily forces them to act more like a liquid?
Well, given the intense, repeated friction and shear forces specific to the G-spot during intimacy, could that constant thixotropic stress actually cause these fillers, both biphasic and monophasic, to mechanically degrade at wildly different, perhaps much faster rates compared to when they are injected into a relatively static, calm area like the cheeks or the jawline?
Oh, wow. Are the very mechanics of intimacy actively destroying the structural integrity of the gel faster than the body's natural enzymes can?
It's a real possibility.
That is an amazing puzzle to leave off on.
It just proves that no matter how precisely we modify molecules in a lab, the human body is a dynamic, unpredictable environment that always has the final say.
The X-ray machine is definitely broken, but the murky waters are absolutely fascinating to explore. Thank you for joining us on this deep dive into the structural properties of HA fillers. Keep asking questions, keep looking past the surface, and we'll catch you on the next one.